Happy to welcome Dr. Emily McCourt to the stage. She's going to talk about our first eye patient that was dosed with an ASO.
So thank you very much for that introduction. Again, I'm Emily McCourt. I'm from University of Colorado / Children's Colorado, and I just want to tell everybody what an honor it is to be here with this group. And I'm really excited to talk about the front part of the brain, otherwise known as the eye. I have no relevant financial interests to disclose. So I'm going to tell this story from my point of view. And then you'll hear the story from Grace's point of view. So about 10 years ago, I met a toddler with poor night vision. On exam, she had bone spicules in the peripheral retina, and so for the non-ophthalmologist in the room, this pigment that's here, it shouldn't be here. And she had a flat ERG, and again, for the non-ophthalmologist, an ERG is sort of like an EKG for the retina, and you can see down here it should look like this. Grace's was pretty flat, and this is a normal picture of the back of the eye. Next, I'm showing you an optical coherence tomography. So, and I don't know why I have it going by itself. One second. So an OCT, you can think of it as like an ultrasound for the eye. So it uses light to look at all the different layers of the retina. So this is what a normal OCT should look like here with multiple layers. And going back to Grace's OCT, you can see there's abnormal swelling. And if you are an ophthalmologist, you'll notice there's thinning of the outer layers of the retina. So with this information, I diagnosed this young child with RP, which is otherwise known as retinitis pigmentosa. She had bone spicules, attenuated vasculature, macular edema. All these things are very diagnostic of retinitis pigmentosa, but what was very different about Grace at that time to me was the severity of her retinal disease, but also that she was a puzzle to all the doctors that she had met so far. So here's her most significant finding in physical exam. So she has a lack of sensation in her extremities, leading to frequent injuries, infections, unexplained fractures, and again, you'll hear from Grace and her mom next. Genetic testing at this time was unrevealing, so Grace is 15, and so this was when she was 2, so this is many years ago. However, she, 8 years later, had whole genome sequencing through a study at Xenon Pharmaceuticals that revealed the disease-causing variants in an FLVCR1 gene, and we finally made a diagnosis for Grace called posterior column ataxia with retinitis pigmentosa, or PCARP for short. So the FLVCR1 gene stands for feline leukemia virus subgroup C cellular receptor 1, which Grace will tell if you listen to the podcast that she did with Stan, she is not a cat. It encodes for a choline transporter, which is important for cell membranes in the retinal pigment epithelium. So PCARP is an extremely rare or nano-rare condition with fewer than 50 cases described in the literature, but most of them losing their vision and having RP later in life, like teens and 20s, not as early as Grace, and none presenting with congenital absence of pain like Grace has. So Austin Larson, who's pictured here, is the genetic metabolic doctor who I collaborate with in our eye genetics team at Children's Colorado, and he said to me, when we got these genes, he said, look at this. This is a deep intronic variant. Maybe we could treat this. So at that point, my goal, of course, is to keep the patient as our North Star. Austin and I called Susan, and we discussed the possibilities and the unknowns. Because we thought this could be amenable possibly to ASO treatment. We thought maybe we could treat one eye at a time, because unlike the rest of the neurologists in the group, I do have an internal control. Sorry, not sorry. And we thought maybe slowing the progression of her ocular disease could improve her quality of life. So after this discussion about the unknowns, and we didn't even know what the risks were at this point, we decided to proceed with some science. But going from an idea of personalized medicine to actual treatment is very complicated, and I had a lot to learn. So I had a lot of the right things: a motivated medical team, great family involvement, patient engagement, financial support, and an established research infrastructure at my institution, which was all super important. But perhaps the most important was a little good luck. So around the same time that we were thinking about treating Grace, our team at Children's in Colorado was working with 2 researchers at Boston at Harvard in Tim Yu's lab to treat another child, one that had Batten's disease that was being treated with intrathecal ASO for, again, for her Batten's disease. So with Susan and Grace's permission, we put our heads together on working on finding an ideal ASO for PCARP, well, for Grace's PCARP. So in Dr. Yu's lab, Bo performed basic science studies, and apologies for those of you who are not geneticists, including myself. We needed to prove first that this intronic mutation was pathogenic. So the change was found to be a 3 kilobase pair in the antisense pseudogene insertion deep in intron 8. RNA sequence analysis uncovered the exonization of the insertion. The insertion activates a pair of splicing sites, and you can see there, creating a pseudoexon with an early stop codon, and rendering the transcript non-functional. And so for the non-geneticists in the room, including me, the abnormal DNA in the intron turned it into an exon, which caused transcription to stop early and dysfunctional protein to be made. So we found that this splice-altering insertion could be potentially treatable, and here was the ASO strategy that we came up with. So, but Bo designed a set of ASOs complementary to the novel splicing acceptor with the goal of designing a therapeutic splice switching ASO. Initial ASO screening pinpointed a promising region where 2 hits could effectively repress the mutant splicing. Fine-tuning ASOs were generated against this region and identified 2 leads that improved the amount of normal protein and decreased the amount of abnormal protein. Further, FLVCR1 immunoblotting confirmed increased protein upon ASO treatment in the patient's cultured fibroblasts. So to actually get the drug produced for Grace, we needed tox studies and drug manufacturing, things that are generally not easy to do in an academic institution. So how do we do these things? So this is where I had a little more good luck. So around the same time n-Lorem was formed. So we had done all these studies with the Harvard group before n-Lorem existed. This is like 2018, 2019. And so the work at Boston really provided us with enough proof of concept to apply to n-Lorem for our patient who used their own top candidate for tox studies and came upon a final drug. So n-Lorem funded and created the drug for the rest of Grace's life. So n-Lorem here was absolutely key to getting over the finish line. They did rodent studies in the CNS, and then monkey GLP studies in the eye, in which we found the no observed adverse effect level, which is the dosing level and figuring out what dose to give. We found very high doses could cause some eye inflammation, which had also come up in some other ASO studies in eyes, so it was not surprising. So with all of this, we applied for and was granted IND approval to treat Grace in April of 2023. So fast forward 8 years. So while all this was being done, and a pandemic came and maybe left, Grace's vision was getting worse. Susan sent me a message that said she cannot see the cup of water unless it's right in front of her. Her visual acuity and her night vision, her exam was worsening, and she had developed an eye drift, which is common when people lose peripheral vision. I want you to remember that Grace has peripheral neuropathy. She doesn't feel any pain or really anything in her fingers, so she can't learn Braille. And she does need her vision to see if she has an infection. She can feel some stuff. I don't want to put words in her mouth. She'll tell you everything. But we thought perhaps if she couldn't see an infection, maybe this could be life-saving. So we created an ASO specific to this patient's deep intronic mutation, and next I present the clinical study and results of 1 and 2 years of treatment. Here's my study. So the primary objectives were to evaluate the safety and tolerability of the custom ASO drug in our single patient with PCARP, and 2 was to assess the changes in eye structure and function in Grace after treatment. So our endpoints, we looked at treatment-related adverse events and SAEs and physical exams to determine safety. And efficacy endpoints, we looked at changes in eye structure. So we looked at OCT, which is again that sort of like ultrasound of the eye, photos, autofluorescence, FST, which is sort of a fancy visual field, and best corrected visual acuity. Going back for dosing, we injected our medication intravitreally, so Grace gets an eye injection every 6 months, and we had a dose escalation plan that we used here. We do this under anesthesia per Grace's preference because she's not really interested in getting injected in the office, which is so shocking to me. But I would mention that for adults with retina disease, we do intravitreal injections in the office routinely, so you just do topical anesthetics to the eye, and it's very well tolerated, but it's completely understandable that when we started this, Grace was 12, so it's completely understandable that she's not interested in getting an intravitreal eye injection in the office. I don't fault her for that. Yeah. She's so shy. Our primary endpoints were achieved, so there's no adverse effects or serious adverse effects thought to be related to the study drug, and you can see all the labs. We did some bloodletting for Grace, checked all sorts of stuff. So the secondary endpoints, I show you this slide for 2 reasons. One, to show you I wanted to make sure everything was safe, so we checked a ton of things. But I really want to show you the commitment that Grace and her family had to doing this study with me, and how many events or how many tests she came in so we could check everything. This is a lot of time and energy on their part. She loved it. Secondary endpoints were all reached with stability and eye structure function. So you can see her best corrected visual acuity here in the right and left eye, and you can notice that they're stable over time. And then here's the 2-year data. That's the first time we're seeing that, and it continues to have stable visual acuity. So this is a busy slide for those of you who don't look at fundus photos all day, but column 1's the right eye, column 2's the left eye, and those are photos. And column 3 is the right eye, column 4 is the left eye, and those are those optical coherence tomography. Again, it's like an ultrasound of the retina, all demonstrating stability over time. This is Grace's visual field on the top row, row A. This is pre-study and this is post 1 year. And both of them, you can see her visual field is quite constricted, which is typical of retinitis pigmentosa. Again, those are stable over time. This is something called fundus autofluorescence, again, stable. This is full field stimulus threshold test, which is her favorite test to do, not because she enjoys it, but she likes the tech that does this test. Her name is Mary, she's lovely. But it's looking at the threshold of light you need to see in different colors. So both eyes, again, are stable. So in conclusion, with the help of n-Lorem, I don't want to give that photo yet. We created the first personalized intravitreal ASO injection. Grace has had great 1-year outcomes and 2-year outcomes with stable visual acuity and imaging. So while my primary goal is, of course, to prevent complete blindness in Grace, my hope is that this work is more than treating blindness in one child. I want to be part of this creation of a pipeline for precision medicine for many children with rare and blinding retina diseases. So none of this science would happen without a brave patient and her family who trusted me, who trusted the science, and who came to so many appointments. There's a giant team, and I am a clinical pediatric ophthalmologist. I never thought I would have a slide like this. I've seen them like all through medical school. Like this was not like on my to-do list. So I'm pretty excited to say this is a team sport, and I've really learned, I've learned to find my people. So it's been really, really fun. This is more of my team, and I'd be remiss if I leave out child life. So if you're at a big children's hospital, child life is really helpful. Grace met with child life every month prior to starting the study so that I could have all the photos, high quality, and everything that we needed to make sure she was safe. So I just shout out to them. And then this is my team with different milestones. And then this is Grace. This is at our last injection, like a couple months ago. She's taught me lots of things about life. She's also taught me a lot about Taylor Swift and an entire genre of books called romanticy, which I didn't know existed. So with that, I think we move on to the next part and actually talk about my patient. So that's it for me.